Hello, my name's Christiana Gordon and I'm one of the lymphedema consultants at St George's Hospital in London. It's my pleasure to give you a short presentation today on behalf of the British Lymphology Society to celebrate Lymphedema Awareness Week 2023, and I'm going to be talking about lymphedema, lipedema and obesity. How do you tell the difference? This talk is aimed at healthcare professionals that may or may not be involved in the care of patients with limb swelling, but also potentially for patients out there who are wondering what condition they might have. So the scenario that I'm going to be talking about is of somebody that has lower limb swelling, and how can we try and work out whether it's due to lymphedema, lipedema or potentially obesity? How do you tell the difference between these three conditions? So first of all, we're going to talk about lymphedema. And before we talk about the clinical signs, I think it's important to just go over what is lymphedema. Lymphedema is the swelling of any body site. An interchangeable term might be chronic edema. It's the same condition. And it develops when our lymphatic system cannot drain the fluid properly from our tissues, and so it accumulates and the limb swells. There are many causes of lymphedema. It may occur as a result of necessary cancer treatment, where the lymphatic system has been damaged by lymph node removal or radiotherapy. However, there are many other causes of secondary lymphedema, and that might be as a result of obesity, varicose veins or varicose vein surgery, not moving enough, inflammatory skin disease, certain blood pressure drugs, trauma, and so on. A smaller proportion of patients may have lymphedema as a result of primary lymphedema, and this is a genetically determined weakness of the lymphatic system. And the onset of lymphedema in someone really does depend on the underlying cause. But what are the clinical clues to making a diagnosis of someone having lower limb lymphedema? Well, typically in the lower limb, in lymphedema, the feet and ankles will swell first before the fluid develops within the leg itself. And there's an old-fashioned term called Kaposi's stemma sign, which is a diagnostic tool that doctors use to confirm the diagnosis of lymphedema. And I'll show you a picture in a minute, but this is basically the inability to pick up and pinch the skin at the base of the second toe because of the lymphatic fluid within that toe. In lymphedema, there will be pitting, and by that we mean you can make a dent in the limb by pressing hard for 30 to 60 seconds. In lymphedema, the leg swelling may be asymmetrical, so maybe only one leg is swollen, or perhaps one leg is swollen more than the other. And this is different to lipedema, where it's very much a symmetrical problem. In lymphedema, especially that left untreated, chronic skin changes will develop, so thickening and bumpiness and perhaps some scaling of the skin. And in lymphedema, somebody might say, yes, I've had problems with cellulitis infections in the past. And this is because our immune system travels within the lymphatic system, trying to pick up where the bugs are infecting and invading us. And in lymphedema, you've got sluggish drainage within that limb, so sluggish immune surveillance. And therefore, you're slightly more at risk of cellulitis infections. Other clues to somebody having lower limb lymphedema will be a response to that limb swelling to treatment with compression. And in the early days, that swelling might improve overnight when they're having a good night's sleep, and then the swelling recurs as the day goes on. So these are all signs that there's a fluid problem, i.e. a lymphedema problem within that leg. However, if there's diagnostic uncertainty, we can sometimes do a lymph scan at dedicated hospitals that have the service to confirm the diagnosis. So I'm just going to share with you some clinical pictures to demonstrate the signs I've talked about with this slide. So here is somebody with lower limb lymphedema. There's a little bit of swelling on the top of their left foot, but in the right leg you can see more significant lymphedema as the cause of the swelling. The foot is swollen and there's increased volume up to the knee. And if I were to press hard on the top of the foot or on the shin, I could make a dent. So that would be the pitting sign, would be positive. And this is the demonstration of the Kaposi's stemma sign. There's lymphedema within the toes and the foot, and it's thickened everything up, and so you can't pinch the skin at the base of the second toe. Here's a demonstration of the pitting sign I was talking about earlier. Somebody has pressed very hard here and made a dent because they've moved the fluid with their thumb. You see this in lymphedema, but you wouldn't see this in lipedema or obesity. unless of course the obese person had developed lymphedema because of their obesity. And here's a picture of chronic lower limb lymphedema that hasn't been treated, and the skin is very unhappy with all of that fluid that's sitting within the tissues, so you're getting these chronic skin changes of lymphedema with thickening of the skin. Papillomatosis and hyperkeratosis are the medical terms we might use to describe this. Here's a slide demonstrating somebody with lymphedema of their right leg, and they've developed a complication of cellulitis. So the redness within the skin is a sign that there's a bacterial infection that's spreading. And this person will probably complain of feeling very tired, might feel flu-like, lethargic, they might have a temperature. And this rash will spread quite quickly over a few days unless treated with antibiotics. And I just thought it might be interesting to share with you the lymphoscintigraphy scans that we sometimes do for patients where we're not sure if they have lymphedema. On the left side of this slide you can see a normal lymph scan. The black that you can see on the screen is the dye that we've injected into the person's feet. At the bottom of the screen there's 2 dark dots, and then over time that dye has travelled up the main lymphatic channels in the legs, and that's the 2 grey stripes you can see going up to the lymph nodes in the groin, and that's a normal lymph scan. On the right you might be able to appreciate that the lymph scan is very different in this person that has primary lymphedema. 2 hours after we've injected the dye, it's still sat in the feet. That's just the 2 black dots at the bottom of the screen on the right, but you're not seeing any dye travelling up the main lymphatic channels in that person's legs, and you can't see the dye travelling up to the lymph nodes in the groin. So just one example of how lymphoscintigraphy can be helpful in confirming a diagnosis of lymphedema. Moving on to another condition that we're trying to work out whether somebody might have if they're presenting with swelling of their legs, and that's lipedema. So what is lipedema? Well, we're still trying to understand this condition. It's not very well understood at the moment, but we appreciate that it's a painful fat disorder affecting women. Only a handful of men are known to have this condition. And the onset of the disproportionate fat build-up on the legs and sometimes the arms tends to occur around the time of puberty or other times of hormonal change, such as perhaps going on the contraceptive pill or going through pregnancy, and sometimes even going through menopause. The more that we learn about this condition, the more we're beginning to realise it may be exacerbated by weight gain. The abnormal fat that's developing on the legs and sometimes the arms is symmetrical, but it's disproportionate, so the person will have a slim torso and then fat deposition on the limbs that's out of proportion. This condition is still mistaken for lymphedema or obesity by many doctors and nurses, but it is fair to say that obesity does complicate the clinical picture in time for many women with lipedema. But when they address their weight, when they lose weight, there is disproportionate weight loss. So they can lose weight from everywhere, but it appears to be much slower in coming off from the limbs. And this can help the clinician or the person to differentiate the lipedema from obesity. And unfortunately at the moment we don't have a diagnostic test for lipedema. So what are the clinical clues for somebody that may have leg swelling due to lipedema? Well, unlike lymphedema, the feet are spared, and if they have lipedema of the arms, the hands are spared. So the Kaposi stemmer sign would be negative in the toes when we pinch them. And the sparing of the feet and hands creates this bracelet effect at the ankles or the wrists. There is an increase in volume of the legs and maybe the arms, but there's no pitting, so when we press it hard we can't make a dent, and that's because the cause of the swelling is due to abnormal fat, not the accumulation of lymphatic fluid. Somebody with lipedema may complain of tenderness as well when you're trying to do that pitting test. The tissues of the affected limbs will be soft and floppy. They won't feel like lymphedema swelling. There won't be any chronic skin changes that we might see in lymphedema. Somebody with lipedema will typically have a low waist to hip ratio, assuming that obesity hasn't complicated the clinical picture. So in somebody with obesity, the waist and the hip ratio might be 1, but in somebody with lipedema, the waist to hip ratio will typically be less than 0.85. Other clues to the fact that the cause of the limb swelling will be lipedema and not lymphedema will be the absence of any history of cellulitis infections, suggesting their underlying lymphatic system is working well and the immune system in the swollen area is fine. And they may report that there's no reduction in limb volume overnight or with the use of compression. And that's because this is not due to a buildup of lymphatic fluid, but due to an abnormal fat deposition problem. So it may be helpful just to compare lymphedema with lipedema. Here you can see on the left somebody with lymphedema with slightly asymmetric lymphedema of both lower limbs, their left leg affected more than the right, the feet are involved. If you were to press hard, there would be pitting, Kaposi's stemma sign of the toes would be positive. And then you contrast that to the lady on the right that has lipedema. She also has leg swelling, but her feet are spared, and the tissues look very soft and floppy. And what we also see is the braceleting effect at the ankles, and you can see that there is an increase in fatty tissue around the knees. We call that the medial knee fat pads, and that's quite typical for somebody with lipedema. And I think you'll probably see that more in fat deposition of the lower limbs due to lipedema than you would in someone with fat deposition due to obesity. So just coming to the end of my talk, I thought it might be helpful to share with you a table which has some characteristics that differ between lymphedema, lipedema and obesity. I've discussed most of them in the talk, so I won't go through them with you, but please do take time to read it if you would find it helpful. But also bear in mind that there are patients that don't fit neatly into just one of these three categories. It is possible for somebody to struggle with both lipedema that then gets complicated by obesity, that may then be complicated by lymphedema. And it's really important to help our patients access the care that they need, to get the diagnosis they need and have an appropriate treatment plan so that people with these conditions don't suffer unnecessarily. Thank you very much for listening and have an enjoyable Lymphedema Awareness Week. Thank you.
First webinar offered by British Lymphologist Society for Lymphedema Awareness Week 2023. Of course, this is also World Lymphedema Day, and we enthusiastically support that too in promoting awareness of lymphedema. But we're going to come back with a short video about that at the end of this presentation. So about today's webinar, it's clear that if a patient is to receive appropriate treatment and support, it's essential to make an accurate diagnosis. Yet so many healthcare professionals have difficulty in clearly identifying which of the three conditions, lymphedema, lipedema, obesity, or perhaps a combination of them all, exist for patients. So thank you to Dr. Gordon for that very clear outline of the difference between those three conditions, and for joining us to launch Lymphedema Awareness Week and to answer any questions arising from the webinar. With us is also Fran Campbell, a fellow trustee and podiatrist from British Lymphologist Society. She's going to assist in managing and responding to some of the questions. So I'm going to hand over to Fran first to ask the first question from viewers.
Margaret, I think we've lost Fran.
Okay. I'll answer the first question. I'll ask the first question then. There's something come up about hormonal stages in life or drugs, and is lipedema affected by situations such as hysterectomy, HRT, or contraception?
Thank you, Margaret. And before we start, happy Lymphedema Day.
Happy Lymphedema Day.
Great question about the potential impact of hysterectomy, HRT, hormonal change on lipedema. I think there is a link. It's not yet clear what that link is. Luckily, we have a lot more research interest in lipedema happening, so hopefully we'll have an evidence-based answer to that question very soon. But I think we can confidently conclude that there is a link with lipedema either developing, so being unmasked by these hormonal change times, or potentially exacerbated, potentially made worse during times of hormonal change, but that's not always the case. I think the hysterectomy is probably more significant if it included having the ovaries removed, but just having the womb removed probably wouldn't be something that I could think would have an impact. I've sort of taken it one step further in my mind about thinking why these times of hormonal change might be linked, because when I've done hormone profiles on my women in the past, both for NHS tests and research settings, I've not found any differences in the hormones themselves. So I'm trying to understand, is there really a close link between hormone abnormalities and lipedema, or is it a bit more complex than that? And I think many women will appreciate that during times of hormonal change, or going on the pill, or going through menopause, we find it easier to gain weight. So perhaps that is the link. Perhaps it's these times of hormonal change and the associated weight gain that is unmasking lipedema or making lipedema worse. That's my current opinion, but I'm waiting for the science to prove me wrong or right.
So following up on that, would you give them any particular advice if they find that they were gaining weight at those times?
Oh, that's a really big question, isn't it? Yeah. So a question often asked of me is, should I go on the pill? Is it safe to take HRT? So that's one aspect that we could delve into. And I think it's all about risk versus benefit. So if we take HRT, as you go through menopause, some of those symptoms might be really unpleasant and, improved by going on HRT. And so I think you have to, as the patient, and maybe with the help of your GP, work out, is it beneficial to go on HRT? Are your menopause symptoms so horrible that you really do need HRT? And in that case, I would definitely support a woman going on HRT. And if she does develop significant weight gain, perhaps explore, is there a different type of HRT she could swap to? Or does she need help with weight loss management, and she chooses to stay on the HRT? And then that takes you to the second way of answering your question, is what help can we give them if they're having weight issues when going through times of hormonal change or hormone therapy? And there are options now for weight management. A few years ago, there wasn't much that could be offered, but we are developing new medical therapies to assist with weight loss. The GLP-1 agonists are proving helpful. Not that I'm advocating everyone with weight gain should go on weight loss treatments, but if you're struggling with looking at your diet and nutritionally changing things to try and lose weight, if that's not working and you're really struggling, then there are other things that can be offered to help.
Okay, thank you very much. Okay, there's a completely different one now coming up about MLD or SLD in people with lymphedema or lipedema. What's the difference? Is the effect different?
I would say definitely yes. So I think of lipedema as a fat disorder with no edema, no fluid problems, whereas lymphedema is obviously a fluid issue that we can influence to some extent with MLD and SLD. So I personally don't think that a woman with pure lipedema will benefit from MLD, because we can't shift a fat cell with massage. And in fact, women with lipedema have pain and they don't want to go for a massage because it hurts. So I don't feel that there is a place for MLD in women with lipedema.
Okay, thanks. And you mentioned pain. Is it worth saying something about what's the possibility of patients with any of those three conditions experiencing pain?
Yeah, so pain's a difficult one to quantify. Pain is different for everyone. What might be pain to me might be something that someone else might dismiss, or someone might be screaming in pain for something that doesn't bother me. So it can be difficult when doing a clinical assessment to work out what pain is like. And when I've spoken with colleagues across Europe and the States, we all have a very different idea for what lipedema pain might be, and that's because our patients report different symptoms. But it could be it could be tenderness, it could be significant pain on palpation, or just, my legs hurt, my legs ache, I feel like I'm carrying cement on my legs. That any sort of discomfort could be classed as pain. But I don't think you can say it's one specific pain for lipedema or not. It varies so much. Lymphedema is often talked about as not being painful, but I think many of us that look after lymphedema patients, will say a lot of our patients do say that it's heavy, it can be uncomfortable when poorly managed, but that will go when they're in good compression and the lymphatic function is improved.
Okay, thank you very much. I see we've got Fran back, so I wonder, Fran, have you got a question?
Hi, Fran.
Hi, hello. Yeah, moving on from pain, what about fatigue? Do you find that's quite common throughout the three groups of patients? And how do you manage that if you want to get people active?
Okay, so I don't run an obesity clinic. That's my disclaimer. I look after women and patients with lymphedema and lipedema, some of whom have obesity problems. So that's where my obesity knowledge comes in. So I can't say how common obesity and fatigue, that I don't know about that, but I would imagine if you're morbidly obese and unable to move much, you're going to feel fatigue. So hopefully with addressing the obesity side of things, you'll have the option to exercise more, and that's been shown over time to improve fatigue. In lipedema, the fatigue may be linked or often diagnosed as part of the fibromyalgia condition, and there is an association between lipedema and fibromyalgia and an overlap between the two, and it's often very difficult to work out whether your pain is fibro pain or lipedema pain. Maybe it's the same pain, we just don't know. So management of that is very difficult. It's often multifactorial, and there may be a psychological component to it as well. So I think you have to help every aspect that person is struggling with. So if they've got pain, you could, and from the lipedema, and they're also fatigued, maybe compression might improve some of that. If they've got obesity as well as lipedema, helping them address obesity might improve their fatigue. Somehow encourage them to exercise more might help, but also thinking, are there other causes for fatigue? Are they anemic? Do they have an underactive thyroid gland? Should they go to the GP and have a set of bloods and make sure there isn't a reversible medical cause for fatigue? And in terms of fatigue and lymphedema, it's not something that I'm particularly made an association with, but I would do similar screening bloods if one of my lymphedema patients complained of fatigue all the time.
Yeah, I think that's really important to make sure that you're thinking about differential diagnosis for fatigue, because that could be also going on in the background. So I think that's really important. Someone's asking in the chat about lipedema and if that's linked to cellulite, is the specific question.
Yeah, not all women with lipedema have cellulite, but many women do. I don't think we should be saying that cellulite is lipedema, because so many women have cellulite and don't have lipedema. But I will say that many of the women coming to me with classic lipedema will say, I remember struggling with orange peel or cellulite on my thighs as a young teenager, whereas my friends didn't. So maybe it is an early sign. But I think it would be dangerous to start going around diagnosing every young girl with cellulite as having lipedema. But again, it's one of the many unanswered questions about lipedema. Hopefully research will give us answers.
Okay. I've got a question that's new to me. Somebody's asking if vitamin deficiency is associated with lipedema.
Not to the best of my knowledge, but maybe I've missed a recent paper. If we do find a paper, we'll post a report in the chat later.
Okay, thanks very much. And also there's a couple of people asking about the benefit of compression for lipedema, which you touched on in the last question.
Yeah. So compression in lipedema, when we're prescribing it, we have to manage the lady's expectations that compression is not going to reduce her lymph volume. Because you can't, like with the MLD, you can't shift a fat cell with compression. Even if you did daily bandaging, you're not going to reduce the volume. But the compression is there to lift and support the tissues, in my mind, and potentially reduce any inflammation, which may be contributing to some of the pain, some of the discomfort. Again, we don't really understand the mechanisms of disease, so we don't really understand how compression can be helpful, but it can in a large proportion of women. I'd say more than half of my patients benefit from compression in terms of pain reduction, potential improved energy, and they like wearing them. If they can find some that fit, they want to wear them. The other side of things is some women will try compression, and because of the tenderness of their lipedema, they just can't tolerate it. And at that point, I'll say, look, we've tried a couple of brands and this isn't working, and we're not going to reduce your limb volume by making you wear them. So let's just call it quits for now and see what happens.
Okay.
Thank you. There's a question in the chat now. Sarah has asked, can you explain a little bit more about the potential link between lipedema and fibromyalgia?
Afraid I can't explain anymore. I'm not a fibromyalgia expert. I don't think the fibromyalgia experts truly understand fibromyalgia yet. So I suppose they're in a similar position to lipedema experts. As we unravel both conditions, hopefully we'll understand whether, you know, what the associations are, what the links are. But at the moment, I can't begin to do that, sorry.
Okay. Someone's asking about cellulitis and if patients with lipedema are at a higher risk of cellulitis than those with normal lymphedema. I don't know whether that means a patient with lipolymphedema.
So a lady with just lipedema, I don't believe is at increased risk of cellulitis, because there is no lymphedema in lipedema as our current view amongst the majority of lipedema experts that I work with, although there are some differing views in other centres. But I think if you've got pure lipedema, you're not at increased risk of cellulitis, and certainly the patients I've seen in clinic that don't have lymphedema as well as lipedema haven't had infections. But if you've got lymphedema, you have impaired lymph drainage, so you have impaired immune surveillance in the legs, and you are therefore at more risk of cellulitis. So I think if you're in clinic and you're seeing a lady who has what looks like lipedema, but there's an awful lot of cellulitis infections, you maybe have to think and go, okay, is this one of these rare cases where the lady looks like she has lipedema because her feet are spared, but actually it's a rather strange lymphedema, often a primary lymphedema mimicking lipedema. And that's where the lymph scan could be helpful in refining that diagnosis. Sometimes that thinking makes it more complicated for us clinicians to work out, is it lipedema or lymphedema? But sometimes there are these conditions where it's lymphedema mimicking lipedema.
Mm. And that kind of fits. Somebody asked about whether lymphoscintigraphy had a role in lipedema, but you probably just explained that when there's any doubt.
Yeah. I don't routinely recommend lymphoscintigraphy in diagnosing lipedema because I don't think it's necessary. I would reserve it for a case where I'm just not sure which one it is, and then I would do lymphoscintigraphy. And I think there was a couple of questions about how do patients access lymph scans. Is that something you'd like me to try and address now? I suppose it depends where you are. It's a bit of a postcode lottery, but most district general hospitals, their nuclear medicine department should have access to lymphoscintigraphy. Now, whether it's something that they do frequently is a very different matter. You know, at St George's in Derby, we're doing lymph scans every day of the week, but in other hospitals that perhaps don't have a lymphedema clinic, they may not have done lymph scans for several years. And then you have to question, is it worth the patient having their lymph scan done at that centre? Because it's all very well having the lymph scan, but perhaps if you haven't got anyone there to interpret the results, what's the point of having it done? So I think a lymph scan should only be requested by a consultant or a specialist that is able to perhaps interpret the report and use the information for the benefit of the patient. We have the option at St George's and Derby consultant-led clinics of importing the scans, so we can access the images of scans done at other hospitals and do our best to interpret them. But I would say that the majority of lymph scans done outside of our centres don't have quantification. So quantification is calculation of how much of the dye injected in the feet travels up the leg over a 2-hour period. And we've had many patients where looking at the pictures of the scans, it looks normal, but then when you do the quantification analysis, you can see a dramatic reduction in the amount of dye travelling. So for me, I think there's only good value of a lymph scan done if it's got the quantification data with it as well. So I suppose the short answer is any big hospital should be able to do a lymph scan, but you have to think, is it worth getting it done there if the results can't be useful for the patient? Maybe it's worth referring the patient to a centre that can do a lymph scan and help answer the question.
Yes. Yeah.
Okay, thanks. Would the treatments be dramatically different in light of the lymphoscintigraphy scan and what you would find, or would they be fairly similar?
It depends on the patient that you're investigating and treating. So if I see a patient in clinic with classic lymphedema history, lymphedema signs, unless I'm sort of thinking this is a very interesting primary lymphedema that I want to explore further with genetics and maybe something else, I don't feel the need to routinely offer lymphoscintigraphy because it doesn't change my treatment plan for that person. And as I said, in lipedema, I would not routinely do a lymph scan. I would probably just reserve it for those cases where I'm just not sure which condition it is and I need some support from the lymph scan. But again, the quantification data is the most important bit of that scan for me. Yeah, that's my thinking there.
Thank you. There's a question in the chat about motivating patients in terms of their lifestyle. And, you know, that's obviously a big part of treatment as well, isn't it? To talk to people about their lifestyle and modifying their lifestyle. So are the lifestyle changes very similar as per all of the conditions, or would you recommend slightly different things depending on if they've got lymphedema or lipedema?
I think you have to tailor it to the patient, and so much of that comes from the skill of the therapist that's seeing that patient and developing that rapport and knowing, trying to work out how to motivate that patient and what information they will find useful and what mode of receiving that information will be useful. Are they better off with leaflets? Are they better off with linking them in with a patient support group, which I think could be invaluable for both lymphedema and lipedema? Perhaps just, you know, asking them to be mindful of how much Googling they do, because Google can be scary, but there can be some good resources on the internet. So I think a lot of it's about guiding the patient to resources that are going to motivate them in a positive way and not upset them, because a number of patients will be on Google and see things and then get more upset and demotivated. And unfortunately, you know, weight management is such a big part of both lymphedema and lipedema that we need to make sure that it's all positive reinforcement and motivation there. Are there any specific lifestyle tips that are different for each one? I'm trying to think. You've put me on the spot, but I can't. I think it's all about you know, embracing your treatment plan, being motivated. You know, this should be patient-led management with the support of a therapist rather than, you know, the patient sitting there passively and us doing treatment to them. So we just need to motivate them however we can. And some patients will struggle. Some patients will need mental health support and counselling, CBT potentially. So we need to link in with the GPs and any mental health resources that we can. And that's something in the UK that we're sadly lacking. I would love to have a psychologist linked to my clinic to help all of my patients. But, you know, that's a bit of a dream. Hopefully one day it'll be a reality. But yeah, I mean, we just need to do everything we can to motivate our patients and give them the support that they need. But I do think that the patient support websites are invaluable for that.
Yeah, I think it is so important to direct people to the right literature, to the right, you know, reputable websites, because you're right, so many people come into clinics saying, I've seen this, I've seen that, is that right? And, you know, a lot of the time it's not really a reputable kind of source that they've got that information from.
Yeah.
Sorry for jumping about a bit, but there's lots of questions coming in response to answers to other questions. But you've already talked about MLD in the place of MLD, or not, as the case may be, in lipedema. But someone's asking about deep oscillation therapy. Do you have a view on that for lipedema?
For lipedema, no, I don't have a view other than I'm not sure that well, I suppose I do have a view then if I'm going to say something. I don't think it will be very beneficial in terms of volume reduction. Could the patient tolerate it? I'm not sure. You know, it's not something that I've ever offered my patients, and I'm not aware of any literature on the fact, but I'm not sure it's something, when thinking about the physiology, would be beneficial or tolerated by a lipedema patient.
Okay, thanks. And kind of linked with that, but other treatment options, someone's asking about surgery for both lymphedema and lipedema, which I know is a very controversial topic at the moment. Apologies.
No, it's a big question. Where do we start? So I can't see that question at the moment. Was there a specific bit to it, or do they just want my opinion about surgery in general?
No, it will just say for both lymphedema and lipedema.
Okay, I'll start with lipedema if that's all right. So
what are your views on surgery to either lymphedema or lipedema?
The short answer is, in the right patient, it's the right thing to do, but we've got to get the patient suitable for surgery, and they may never be suitable for surgery, and that's something that we have to realize. So if we think about lipedema, we know that liposuction is something that has been offered for many years now, often with good results, but the good results happen in the right patient. So liposuction, I don't believe, is a cure for the condition, and many women have gone and had great results from their liposuction, but weight gain after surgery has encouraged recurrence of the fat, so more liposuction is needed. So it's more expensive for them, there's more risk of complications. So you have to get the patient ready for surgery. And I think to get someone ready for surgery, they need to not have any obesity fat going on, and they need to be in control of their weight and able to manage the weight after liposuction so that they don't get recurrence of the fat. They need to be aware that sometimes there are complications, and they need to do research and make sure that they've got a surgeon that has the skill set to offer liposuction. But I think in the right patient, liposuction is definitely an option, and something that I would like many of my patients to be able to access, but the NHS sadly at the moment is not doing so. What else can I say about liposuction for lipedema? The evidence suggests it reduces pain. So I think as long as the patient understands the benefits, so pain reduction is not guaranteed, but might be possible. Limb volume reduction might be possible, might improve mobility, but it's not curative, and you're never going to have, perfect legs. You can't be doing it just for cosmetic reasons. Then I think it's something that should be offered to them, but we just can't at the moment on the NHS. In terms of lymphedema surgery, I have to say a disclaimer again that I'm not a surgeon. So you have to bear that in mind when listening to what I'm saying. But, broadly speaking, there are 3 types of lymphedema, well, that's 4 types of lymphedema surgery. Debulking surgery, like the old-fashioned Charles procedure, which, should very, very rarely be considered. Liposuction, which is NICE approved for lymphedema treatment, lymph node transfer surgery, and LVA anastomosis surgery, where the surgeons sew the lymph vessels into nearby veins and try to sort of bypass the lymphatic circulation that way. So if we exclude debulking surgery, because that's very rarely suitable, those 3 procedures are 3 very different operations, and it's about patient selection and trying to work out what you're trying to treat. So in the UK, liposuction can be offered at St George's on the NHS, but there are funding restrictions, and the patient has to be the right patient for surgery. Again, weight management must be addressed before surgery. They must be able to tolerate compression, because after liposuction surgery, we've damaged the lymphatic vessels, and they'll have more problems in controlling the fluid afterwards. So they have to be compliant with really heavy duty compression, flat knit, often a 4 thigh length with a 2 over the top, and sleeping in garments. So that's a big post-operative treatment plan they need to be signing up for when they're having liposuction. But saying that, you can get great results in terms of dramatic volume reduction and reduced risk of cellulitis and significantly improved quality of life. So I am a fan of liposuction if it's done for the right patient and everyone's on board with post-op care plans. LVA surgery and lymph node transfer is not something that we offer in our centre at St George's. But I know it is offered in the UK. Perhaps LVA surgery is a bit more popular than lymph node transfer. And I think done by the right surgeon and the right patient, yes, you can have improvement, perhaps more with the LVA surgery than the lymph node transfer. But again, it's about patient selection. And yeah, I think based on the patients that I've seen that have gone and had surgery, patients undergoing liposuction seem to be happier with the outcome than those having other surgeries. But maybe that's just based on the cohort of patients I've seen.
Okay, thank you very much. Fran?
Sorry about that. So what are the other kind of psychosocial issues that people with, say, lipedema might face that you've come across?
They've typically had a very difficult time of things by the time they come to my clinic or have seen their first lymphedema therapist. They have a body that doesn't conform to current societal expectations of what the ideal body type is or what is aesthetically pleasing. So they're struggling with that. They have often been told by their GP or other doctors, you're just fat, go away and lose weight, stop bothering me, which is very distressing, especially when that message is repeated. a number of patients that I see in clinic have developed eating disorders along the way. So, they have body dysmorphia and eating disorders that, influences their weight gain and loss. And in my experience, yo-yo dieting really does encourage lipedema fat to build up, and makes the woman's body look even more disproportionate, which then has even more negative effects on their mental well-being. They face so many challenges, so they often really just need support and kindness by the time they come to our clinic. And I'd say it's pretty normal for women in my clinic with a diagnosis of lipedema or a new diagnosis of lipedema to cry. Sometimes it's tears of anger and frustration. Sometimes it's tears of relief that finally there's an answer. And, I had a woman this morning in my clinic say, it's such a relief to know that it's not my fault. There is a medical reason behind this. She said, I was so worried you were going to tell me, that I didn't have lipedema, and then I'd be back to square one. So they face a lot of challenges, and I really do feel that I'm not supporting them as well as I should be able to, but the resources just aren't there. But hopefully, if we can diagnose women earlier and signpost them to various ways to help manage their condition, they won't have so much suffering as they have done historically.
Yeah, I think it does help when people are given the diagnosis, especially if they've been to a lot of different places before they actually get that diagnosis. It really does help them to know that it's not their fault, and it is something that has got some form of a treatment plan, which is very good. So thank you. Margaret?
Okay, thanks. There's a couple of people asking about Lipo lymphedema as a term and what it means, and also, does lipedema increase the risk of lymphedema? So could you say a little bit more about that interface?
I will try. It's a controversial area at the moment. So there's almost two schools of thought about lipedema and lymphedema. So I'm currently in the school of thought where I don't think that lipedema is due to lymphedema or related to lymphedema, but women with lipedema can get lymphedema. And that's where the term lipolymphedema has come from. It's a term that I no longer use in my clinic. That's a personal choice because I find it's confusing for everyone. I think you can have lipedema and then develop lymphedema. What we're trying to work out is why women with lipedema, or why some women with lipedema, develop lymphedema. And my current theory is that it's obesity related. So as we're realizing, lipedema and obesity, they go hand in hand much of the time. Again, trying to explore that relationship as well. That's another research question that needs to be answered. But we know that in someone with just obesity, they can get lymphedema. So obesity is a cause of lymphedema. So, it stands to reason that, women with lipedema that have obesity as well can get lymphedema. So that's the current thinking, by me anyway.
Yes. Okay, thanks very much. Fran, anything else?
Yes, there's a question in the chat from Patricia saying, is hydration and salt intake a contributing factor to lymphedema?
I would say that not long term. So I don't think that if you alter your, fluid balance, fluid restrict, or some patients say, I need to drink more, I need to flush things through. I don't think that's going to have a long-term benefit. But I think nutritionally there can be a short-lived impact. So if a patient with lymphedema goes and has a very salty meal, the next day they often report that they've retained more water, and their lymphedema is a bit worse. But then, by the end of the day or within a couple of days, they're back to their baseline. So I think potentially there's a short-lived impact of differencing in salt values. And we do have patients that have other medical conditions and have lymphedema, and we've noticed that if their albumin levels are very low, then their lymphedema is worse. I don't recommend that we all go around checking our patients' albumin levels, but if somebody does have a liver problem, their albumin's low, or other issues causing low albumin, that can impact on their swelling thing. But I'm sure in the lab setting, there will be an effect of differing values of water and salts in the body, but in real life, does it make a big difference? I'm not sure.
Thank you.
Okay, there's another specific question come up about, is it possible to explain why people with lipedema bruise easily?
I haven't got the
Is there
scientific answer for that one. I've got a little hypothesis that's just my thought, that I think the fat in lipedema is different to normal fat. When I've been doing some biopsies, we take deep biopsies of the fat to go and do some tests on. And when I put it on the operating table as I take it out, so it behaves differently to normal fat. It just sort of splodges like a blancmange and oozes over the table, whereas a normal biopsy of fat, will stand fairly proud until I put it in the pot. So I think the lipedema fat perhaps doesn't cushion the little vessels so easily and makes them more fragile. But, again, this is just me hypothesizing. I can't prove it yet, but maybe some clever scientific team will at some point.
Okay, thanks very much. I mean, it just highlights how little we know. I mean, we know a lot more now than we did 5 years ago, but there is still so much we don't know about both lymphedema and lipedema, and we're doing the best we can with what we do know, and based on the pathophysiology and the science where we don't have evidence. So thanks very much. Just as a comment that's quite interesting, somebody who's an exercise professional but also has lymphedema, and saying about they found what's really beneficial is rebound exercises, because it kind of protects the joints. And I know people with lipedema can often get joint pains. Is that kind of exercise, we say, good for lipedema patients too?
Depends if they can tolerate it. So women with lipedema will often have knee pains, and I used to think that this may be, age related and weight related, but I am seeing the knee pains in younger women who haven't got any obesity issues and haven't been around long enough to develop wear and tear like the rest of us. So I think we don't really understand why they get joint pains, but we have to try and encourage them to exercise and be healthy in a way that doesn't hurt their joints. And I'm not sure that rebounding necessarily is kind on the knees. I would have thought something water-based might have been better, aquarobics or swimming. That would be my recommendation.
Yeah. Okay. Fran, anything else?
There's a question in the chat about amlodipine, sorry, let me just bring it back up again. So it says that a general practitioner is aware of amlodipine and the cautions for lymphedema patients.
The answer is no, they're not. The number of referrals I get from GPs saying, locally saying, please see this patient. And you can just see on the referral letter, they're on 10 milligrams of amlodipine. And I just feel like tearing my hair out going, how many times have I written to you saying your previous patient you referred, they're on calcium channel blockers? So yeah, GPs aren't aware. I would love to somehow develop some kind of training so that all GPs become aware of it. And the trouble is you tell a busy doctor something and then bless them, they forget it because they've got other things they need to remember. They're not going to remember that all calcium channel blockers are potentially exacerbating lymphedema or potentially causing lymphedema. And for those that don't know, calcium channel blockers paralyze the lymphatic vessels. Our lymphatic vessels pump every few seconds by themselves. They're very amazing cells that sort of have a natural pacemaker that make them squeeze. But calcium channel blockers paralyze them, so you lose that benefit. And that's why GPs should be aware that anyone with swollen ankles, they should look at the medication list and see if they've got any calcium channel blockers like amlodipine, lymphoedema. Unfortunately, if you've been on the calcium channel blockers for a while, perhaps more than 6 to 12 months, the damage is likely to be long-term, permanent. So even if you stop the calcium channel blockers, the lymph system never fully recovers. But I do think it's worth still swapping it in case, in case you can get some improvement.
Thank you.
Okay. Somebody's asking if alcohol intake has an impact on lymphedema.
I don't know the science behind it. I've had a few patients say if they have too much beer or too much red wine, they're a bit more swollen the next day. But not something I've researched.
Okay, thanks. I think we probably aren't able to answer any more questions in this session. We've come to the end of what we've got time for. And we will try and pick out some things, maybe answer on social media or follow up if we can. But really want to thank you, Christiana, for giving your time for this, and Fran for helping with this. There's been a lot covered and a lot wide-ranging questions coming up, and hopefully maybe have a dialogue going after this, because we will be sending a link to anybody who's registered for this. And some of the questions, like compression, may come up in subsequent webinars this week. So please do register for them if you are interested. And even if you can't watch them at the time, you will get the link that you can follow up. Also, there's lots of resources on the BLS website on lots of these topics. And as both Fran and Christiana said, there's the Lymphedema Support Network, Lymphoedema UK, are great sources of support and information for people with any of these conditions. So in terms of BLS, we're continuing adding to some of the resources, and we do hope to have new revised guidance on managing lymphedema and those who also have obesity later this year. But the best way to find out about anything new coming out, to sign up as a friend on our membership page. It's no cost, and then we'll inform you whenever these become available. So in addition to Fran and Christiana, I'd also like to thank our sponsors. We heard from Hadnam and Juzo, who made these webinars possible, and everybody out there who's supporting Lymphedema Awareness Week and World Lymphedema Day, and everything that's helping to improve our understanding, knowledge and treatment of people with these conditions. So I'm going to leave you with a short video produced by our colleagues in the Lymphatic Research and Education Network to mark World Lymphedema Day. So thank you everyone again.
As we celebrate World Lymphedema Day, we are united in dreaming of a cure. On March 6th, we raise our voices for all our sisters and brothers who suffer from lymphedema across the globe, letting them know they are not alone.
We support World Lymphedema Day.
BLS supports World Lymphedema Day. I support World Lymphedema Day. Yes.
We support World Lymphedema Day.
Support World Lymphedema Day. Malta. We support World Lymphoedema Day. Yay!
I support World Lymphedema Day.
I support Lymphoedema Day.
I support World Lymphedema Day.
And I support the World Lymphoedema Day. Yay!
I support World Lymphedema Day.
Join World Lymphedema Day.
If we want to win this fight, we need to stand together and educate the world.